Okay, let's get started. For those of you that I don't know, my name's Bridget Young, and I'm Vice President of Operations. And Bridget Knigley and Amanda and I are going to talk a little bit about care transitions today. And really appreciate you taking time to come and kind of step above the daily craziness of planning your visits and getting all the folks seen to talk a little bit about care transitions, because we're realizing that more and more this is becoming a really important part of our business, of the business of home care in general, but of the VNA specifically. That home care really does have a role in care transitions that's even probably greater than it's been over time. And as all of you know, we've always had an important part in transitioning patients from the hospital to home, but frequently in healthcare in general, I think you see a lot of people working in silos. We have the hospital and the discharge planner, and their concern is to get the patient out of the hospital and hand it off and then take care of the next patient. And our responsibilities are to admit the patient and make the visits we need in home care and then hand them off maybe to the physician or to the family or whoever. But now it's becoming more important from especially a financial perspective, let alone the patient, that we have more integrated care transitions. So we really want you guys to think about that higher kind of level of what we're doing with care transitions as we begin to partner with hospitals. They are looking for home cares that really can meet the needs of them in handing the patient off, and so we want to be that agency for them. So I'm going to just do a little bit of overview. Bridget's going to talk about what we see as kind of our care transition model as an agency, and then Amanda's going to talk about a couple best practices today. And we'll probably have at least one session like this, or maybe two, to talk about some other best practices so that you have the tools you need to have successful transitions. So nationwide, readmissions are a driving factor in the escalation of healthcare costs, and I think we're seeing that through a lot of the activity in Congress and the Affordable Care Act, that there's a lot of focus on containing healthcare costs. The cost of Medicare for unplanned hospitalizations in 2004 is the last data that was available, but it was $17.4 billion nationwide. And so I'm sure in 2011 it's even a greater number than that. So it's quite an expense to Medicare and then of course to all of us. One of the things that, of course, there have been a lot of studies on readmissions and how to prevent them, and one of the things that kind of stood out is that half the patients readmitted had not seen their primary care physician between readmission and the original discharge. And because of that fact, there's a lot of emphasis to get patients back to their doctor right after they've been in the hospital. And I know there's sometimes we run into barriers there. Sometimes it's the physician, the primary physician, saying, well, they were just seen by a hospitalist a few days ago, why do they need to see me? Sometimes it's the needs of the patient, transportation, just making the appointment. But we're seeing more and more that the discharge planners in the hospitals are actually scheduling the revisit appointment with the physician before they actually leave the hospital. So our role in that is just to make sure that that happens. Preventable readmissions are viewed as a serious quality issue as well as a cost issue because they're often indicative of poor care or missed opportunities to better coordinate care. I think from our end, I think the care that we provide, I think we do a really good job of providing care. Hopefully talking about the transition model today, it'll make maybe your at least initial involvement with the patient a little more robust in terms of what you actually accomplish on those admission visits. But I think the opportunity to better coordinate care is huge. Our clinical liaisons are very well aware of this, and I think really try to the best of their ability to get as much information as they possibly can for you when you do your admission visits, but they can't get 100% of it. So there's still a lot falls on the admission clinician to gather a lot of data and coordinate back with the physicians or the hospitals or wherever patients are receiving care. There's also probably an emphasis on expanding home health access. I know we did some work with CIMRO of Nebraska, who's our quality improvement organization, a year ago on care transitions, and they looked at the expenditures, Medicare per beneficiary expenditures in Douglas and Sarpy County is way under the national average. So we know that home care is not utilized in our community to probably the extent that it could be to help, number one, to help patients, but also to prevent readmissions. So I think the hospitals are looking more and more at that and may be more inclined to refer to home care maybe than they had in the past. But they statistically, patients who utilize home health services after hospitalization had $1.7 billion less in expenditures over a 2-year period. So not only like right after that hospitalization they were maybe less likely to go back, but the self-care management things that were taught to patients by the home health care nurses helped the patients recognize their signs and symptoms and keep them from exacerbating their care. So it's just a reminder to all of us that symptom management that we teach is more than just, check off the care plan, I did that. It's really helping patients to stay healthy and happy at home, which is what they want, and to reduce expenditures to Medicare and other insurers. So the potential savings is approximated at $31 billion over the next 10 years if more home health services are utilized. So I think, with these kind of statistics and with the growth of, seniors, that home health care is just going to expand over the next several years. I think one of the things that we're trying to do now is put this process in place with orientation preceptors to help our new staff really learn all the skills they need to do all of these things to help keep patients out of the hospital and to keep them healthy and safe at home, so that we have a kind of a process in place to bring on new staff. Because really, I think even though the economy is crunching down and Medicare payment to us is crunching down, I think there's going to be growth in our industry. So we have to be prepared to have enough staff to meet the need. And I know that a lot of you guys have just been working like crazy because we don't have enough staff right now. But we have 3 in orientation. I know at least 1 or 2 starting next month. And we're continuing to really put a strong emphasis on bringing in new staff. So just so you know that, if you have any friends that are interested in employment, be sure and make a referral, because I think this is a great place to work. So this is a little preaching to the choir, but why is hospital discharge such a vulnerable time for patients? They lack support or understanding of their complex plan of care. I think that's especially true for patients that have a new diagnosis with that hospitalization. Many of the patients have multiple chronic conditions. I think sometimes we might have a patient with, say, a joint replacement that doesn't have a lot of comorbidities, but other than that type of patient, almost everybody we see has more than one thing going on. Many times patients have not returned to their baseline physical state at the time of discharge. They're happy to be home. A lot of times people are encouraged and they think they're doing so much better, and then day 2 after they're home, they're exhausted. So it's a vulnerable time because they aren't where they were before. And I think that kind of feeds into the homebound discussion that we're going to have a little later that Amanda's going to do. Many of the patients we see experience cognitive function decline, and most have multiple medications, and they're possibly even ordered by multiple physicians. So those are the kind of things that you see every day that kind of feed into the need for our kind of stepped up role in care transition. The gaps, post-acute providers, which is us, home care, and skilled nursing facilities, may not receive adequate information during the handoff process. Even with our clinical liaison force and the work that they do to try and get information, there are still times that you don't have everything you need. So that's definitely a gap, and we're working on ways to try and improve that. Family members may be inadequately prepared. They may not have been present during the discharge instructions that happened in the hospital, and so the patient comes home with a yellow piece of paper and tells them what to do, and the family didn't have an opportunity to ask questions and be involved in that. Patients with advanced chronic disease and their family may not have had the opportunity to discuss end-of-life options. In our work with some of the different hospitals that we're doing on readmissions, I think Bridget's going to talk a little bit about that. That's brought up more and more by the hospital social workers and discharge planners, that they see a lot of the readmissions they have are patients that are really toward end of life, and nobody's had the discussion with them of what their plan of care needs are and what their wishes are. So we have a unique opportunity here because we have palliative care with Sherry Heavey and Dr. Sauer that can see patients and have those end-of-life planning discussions. So keep that in mind for a referral source because it's a big factor in patients' dissatisfaction, number one, and hospital readmissions, number two. So some national solutions that are kind of out there. They're innovative payment reform that offers real promise for improving the quality and coordination of care is kind of the goal of national reform. And that is both with Medicare, Medicaid, as well as with insurance companies. So there will be some kind of a financial incentive for the kind of care coordination that can help patients from returning to the hospital. Obviously, hospitals are really interested in this. There's some talk out there, and I don't think this has necessarily been finalized, but in 2013, which is not that far away, about a little over a year from now, hospitals that have a high rate of readmission for certain conditions, I think right now they're looking at congestive heart failure, acute MI, and pneumonia. If they have a too high of a readmission rate on those types of patients, they'll have a reduction in their Medicare payment for 100% of their Medicare admissions for that time period, whether it be a quarter or whatever. So that's a huge incentive to the hospitals from a financial perspective to not have patients come back to the hospital. So they are looking for partners, us, and skilled facilities and other people to partner with them to help keep patients out of the hospital. So that even enhances more our responsibility and our role in care transition. One of the things that just came out last week, August 22nd, CMS announced a new initiative to bundle Medicare payments to physicians and other providers in an effort to encourage care and coordination and reduce costs. So when they talk about bundling payments, that means all the money comes together and the hospital gets some and the physician gets some and the home care gets some. So it's no longer that home care can just say, oh, the patient meets criteria, I'm going to bill Medicare and Medicare is going to pay me. It's going to be in the whole continuum. Was the hospital, did they refer to a home health agency that would help keep their readmissions down? And if we do our part in keeping readmissions down, and the SNFs do their part in sending people back to the ER instead of taking care of them where they are, then we'll be good and may even be in line to have some financial reimbursement back to us in a positive way for meeting those goals. So this new system created by the federal health reform law reimburses care providers for the patient's entire treatment process rather than for each service. I think they're looking at somewhere between a 30-day episode up to a 90-day episode of bundling all that care together. the Affordable Care Act, or the Federal Health Care Reform Law, said that some of the bundling initiatives had to go into effect in 2013 as well. But there's an opportunity to do some pilot testing, and so they put 4 models out there for hospitals and post-acute providers to look at for what do they want to test and see what would work in our environment. So some of the hospitals that we're partnering with are looking at possibly doing one of the pilots. So if you do a pilot, you have to have your application in, I think, by November something this year, and it may start even in 2012. So we may be piloting this kind of opportunity even next year. The most likely of the 4 models will cover the acute care hospital stay plus the associated post-acute care. There's some different nuances there where some just cover the hospital stay and the doctor, some just cover the post-acute section but not the episode of the acute stay. But the most likely one, I think, will cover all the hospital stay and the post-acute care. So it's on the forefront. So how can we help? There's been a lot of work done on transitions in care, and some of you may be familiar with Eric Coleman model, which is a care transition model. And there are parts of that model that are very applicable to home health care and to the work that you're doing every day with patients. So the OASIS assessment, even though I know that's a pain sometimes, and it's like you're feeling like it's something that takes forever and you need to go through it to get it done. But the OASIS assessment is really valuable in identifying what the chronic care needs of the patient are, because there's functional assessments, there's medication management assessments, there's depression screening tools, and those are kind of the 3 big things that drive plans of care that are going to help people stay at home. So when that assessment is really done well and you use that to help do your care plan, you follow that by the interventions that you designed based on those needs, and then that's reviewed by the physician, then you're bringing everybody together in that plan of care, the patient, the physician, and the home health care, to do our part in that bundled continuum of care. So this is the care transition model that we've kind of just tried to lay out for VNA, and Bridget's going to talk a little bit more about the individual pieces, but if I can, I'll just say a couple things and then pass it off. But I think the important thing that it's patient-centered, and we all know that, and we all think that patient-centered is important and say it's important. I think, unfortunately, because of all the rules and regulations in home care, sometimes we get caught up in what our needs are. Like, I need to get this OASIS done, I need to get this 485 done, I need to plan my next visits, I need to do this, I need to do that. And when we're thinking I need to do, we're not really thinking patient-centered. So I just think that when you're doing admissions, at least at some point in the admission visit of doing all your things that you have to do, that you stop and put the patient's hat on and say, okay, now what is this patient thinking? What else do I need to do for them? So the 4 kind of tenets of this model are medication management, early physician follow-up, symptom management, and self-management, which is kind of part of our discharge process. So I'm going to turn it over to Bridget Kniglia.
Just as Bridget just mentioned, well, first off, good morning. Good morning. I think as what Bridget just mentioned is a really good point when you think about that patient-centered focus. I think for our leadership team, as we sit back and look at all these opportunities for us to continue to work on quality improvement, how do we partner, really what it comes down to is patient-centered care. So a lot of this model, Bridget really put together after we'd had multiple meetings with key partners out in the community. Really, what do they count on us for? What do they need from our team? So when you step back and you think of, okay, what does the patient need? what does the VNA need, and what do our partners need from us. You know, when you think about your role in home care, it really is these pieces. You know, what's happening with their medications. You know, do they know how important it is that they get back into their physician's office, not the hospital, into the physician's office within a set number of days? Do they understand what the major issues or risks are for their health? Do they know if they've had a significant weight gain? Oh, you know, this is serious, I've got to do something. And then do they have the tools they need to manage those issues at home? So we were trying to put on, Bridget was trying to put on paper kind of those priority focused areas. You know, we talked a little bit about, many of us come from hospital environment or acute care, and you hear, you know, hospitals talk about core measures, you know, how quickly were we able to give an antibiotic within an hour of surgery. You know, somebody comes in with an MI, you know, how quick were we with certain interventions. For us in home care, you know, we want to make sure that all of our team is knowledgeable of, you know, what are the key things that all of our clinicians need to be thinking about for that patient. So we work so hard on OASIS and orders and documentation, but really it's focused on, you know, what does that patient really need from us. This next slide I love because I think it really depicts the important aspects of, you know, to the far left here, you've got the big broad messages of medication management, early follow-up and symptom management as we discussed. But really, if you look at that, that's, you know, kind of big picture here, you know, here's what we're going to do. But really, you can just take it right through. Okay, that could be very task-focused. And sometimes I know we do get task-focused because we're so, all of us, you know, pressured for time, pressured for resource, those types of things. But if we really look across the continuum, it means much more than just medication management. You know, making sure the patient's familiar with their meds and that they're competent to be able to manage their medications. Making sure that patients have access. You know, you worked with them on their medication profile. Do they have the meds in the home? If they don't, do they have an ability to get their medications? And then even bigger than that, which you all see day in and day out, is that adherence and you know, really focus on, are they going to be able to do this? Are they ready to learn? Are they able? Are they committed? You know, so taking it all the way across. And I think for us, when you look at all of these issues, we really want to be across the continuum. So you look at early follow-up. Okay, is the appointment scheduled? Many times our patients will say, yeah, I'm going to get back into my doctor's office. Well, taking the next step of, you know, when is that appointment? Making sure that you talk about why that appointment is so important. And then, you know, are they able to get there? They may tell you, yeah, I can get him, I'm going to go next week, but maybe we don't know that they don't have transportation. And there's some things we can do to connect them. And I think you guys saw Amanda sent out an email, just a reminder of, hey, many times these patients need help with finances, transportation, all those things that social work can help in partnership. And then also, you know, making sure that they have access to us in between those scheduled appointments. If they're at home, they have, you know, questions, concerns, that they know they can call us. And instead of, you know, I'm going to just go back in the emergency room. I don't know if you guys realize, but at Jenny Edmondson and Council Bluffs, they tell us the majority of their admissions come back through the emergency room. So, you know, really when you think about that, we play really a key role. Symptom management. Not only do our patients comprehend the signs and symptoms that require our attention, but also, you know, do they know who to contact and when to contact? You know, maybe they are noticing they have some weight gain, but they're going to let it go several days. No, we want you to call us right away so we can properly intervene. And also, as far as symptom management, just exactly that. Are they problem solving in a way that we really need them to? And are we supporting and helping them to institute some behavior change? So you can see, for us, it's, you know, really easy for us to say we focus on medication management and doctor's appointments and those kinds of things, but really do we? We need to think about really what are those key interventions. Our partners that are, you know, in acute care and assisted living, skilled facilities, when they think of the VNA, they think of us doing all those things to the right. And we just all need to be on the same page that really is our focus. And this slide, I was just thinking a little bit about, you know, our home health plan of care, all the key aspects that we focus so much on. If you look at all of these pieces, I mean, you could, after every single sentence, say to prevent rehospitalization. So reconcile medications on the admission visit. Well, I mean, everything is about preventing rehospitalization, which is about patient-focused care. We're wanting to make sure that we reconcile the meds upon admission. We know that medications and problems with medications cause readmissions. We know that the majority of patients who end up back in the hospital have not seen their physician within a timely amount of time after their hospitalization, or just in the course of their normal treatment. We want to make sure that we're using them emergency care plans with our patients so they understand, okay, really here are the symptoms and the things I need to be aware of. Here's the area where I'm okay, here's the area I'm not, and what am I going to do about it? And that patients readily understand and know, what concerns should I be watching for, and what do I need to do, just as we talked about the previous slide. The other piece is we've tried to really focus, especially in this last year, as we've partnered with other hospitals on the importance of that work for 30 days. As Bridget mentioned, those patients who are rehospitalized within 30 days are a big issue. And our hospitals right now, every month, are looking at, okay, the previous month, what patients came back in and why. And so for us, knowing that they're counting on our care, our focus has really been, okay, what are we doing in those first 30 days to prevent that? Let's look at this in partnership. So, for instance, there may be a situation where we're ending care on a cardiac patient, but we may continue to monitor through home med because we want to be able to be effective with that. But our goal is really to keep those patients on 30 days to be able to be good partners and to have good results. And really, what does this mean for the VNA? I think for all of us, I think it's very clear, all of us are committed to really good care for our patients. We know, I mentioned to new employees and I meet with them, we have a big task at hand. For many of our patients, we are kind of the last chance for them to be able to stay in their own environment, and that's a big job. And we know that our patients want to be able to stay at home. They want our assistance, and when you think about just the VNA mission of what we do, it makes perfect sense. A lot of times when we're faced with tough situations or challenging decisions, we go back to, really, what is the mission? And as I make this decision, how does it support our mission, our vision, our values, those kinds of things? I think the other piece that we've talked a lot about in this last year as we've partnered more and more with acute care is, that acknowledgement that it's so important that we have a patient that is engaged and a family that is engaged. I think there are times where we have some very challenging patients, and you know better than I do, we have some challenging situations. For us, we want to be that type of objective caregiver that can step back and not talk about, yes, we all have to say sometimes we have a challenge, but not talk about this patient is really non-compliant, the family's not compliant, it's past our point. It's really stopping what you're doing and looking at, we have an obligation, and this is our business. We work with some of the most challenging cases. What are we doing? So focused on what the patient's struggling with, really what are we doing to help them? How are we trying to engage that patient and family in why we're in their home, what we're doing for their care? The bigger picture of what impact that would make is really important. So this piece, I want to talk a little bit about collaboration and partnership. I think I mentioned in this last year, I think some of our most rewarding work has been in partnering with several different providers. We're doing quite a bit with Nebraska Medical Center, Jenny Edmondson, and Methodist, and I want to talk a little bit about that. Really, I think in the last year and a half, Bridget and Amanda and I have seen a real partnership. Those acute care providers are reaching out to us and saying, how can we really partner? Can you help us? I think we're at a point where acute care is really recognizing, as they focus on those patients that are coming back in, home care has a big role in this. Not only are they recognizing that there's patients that have not been referred to home care, they're recognizing that, hey, these patients have been referred to home care and sometimes they still end up back. What do we need to do? So specifically with Methodist, we have been invited to meet with them monthly to look at their readmissions. So every month, Bridget and I meet with a group of folks from Methodist to talk a little bit about some kind of priority-focused patients that they work on, and then also to look at what are we doing with readmissions? Who are those patients that come back, and what are the interventions that we have or have not done? So for us, really it's important that we're doing this kind of work here in the agency so that as we go to those meetings, we have a good feeling of, what, whoever it is that's on that list, we know, we've done all the pieces that we need to. It's been very interesting to look at who those patients are and to look at what happens with them in the acute care environment, and then what we did or did not do. And what I can tell you, in most of those cases, we've seen some really, really good care provided. But for us, it's all of us stepping back and realizing that not only are we working for the patient, we have an acute care provider out there that's really counting on us. They're saying, okay, if I'm referring to the VNA, I know they're going to reconcile meds, they're going to call me if there's a problem, they're going to counsel or teach this patient on symptom management. Some of the other things that we're doing, just a few examples, Jenny Edmondson Hospital, they are now getting a group of providers together about every quarter. They have home care providers all come together. So here, Bridget and I are in a room with all kinds of providers. Small agencies, big agencies, some who are very well versed in home care, some who are not. But a lot of conversation with Jenny Edmondson on the same types of things. Face to face, what are we doing with that? How are we preventing patients from coming back in? How are we treating patients with pneumonia in the home? Those kinds of things. With Nebraska Medical Center, they have also extended kind of a hand out to us to say, okay, what can we do in partnership? Let's look at some different opportunities that we have to work together. For instance, at Methodist, you all know we have a pretty active program with them on congestive heart failure. Carrie Loftus is the nurse practitioner there. She has ongoing interaction with Michelle Wakefield and Deanna Kim, just making sure that as we treat those patients from an acute care standpoint and then they come to the home, as we get ready to discharge, we are communicating back to them. And this is just kind of that continual loop. The Med Center is at the point where they're asking to be able to do some of the similar types of programs to try and really be strategic. I'm trying to think of what else. Amanda and Bridget and Michelle, are there other things with the Med Center or Jenny Ed that we've been doing that this group should know about? I know with Jenny Ed, we've been working quite a bit to have their nurse case managers come out to our office just to see really what we do in our specialty teams. So I guess the bigger picture of this, you guys, is just knowing that every month on a regular basis, we're meeting with those acute care providers and talking about what are they doing, what are we doing, and trying to really, coordinate. I think just a small side note, Michelle and I met with them and Sherry Page a few months ago with Methodist to talk specifically about pneumonia. They wanted to know, okay, here's what we do in the hospital setting, what do you do in the home care setting? And it was very interesting to just sit back and look at the conversation because it was very fragmented. Really good intentions on all part. The hospital really has their key priorities. We in home care have our key priorities. But some of the most basic, simple things like, okay, patient has pneumonia. Should we be using incentive spirometry? Well, oh my goodness. It was very, you had everything from respiratory therapists at Methodist that said, no, incentive spirometry is only for, fresh surgical patients, not for patients with pneumonia. You had clinicians in home care that said, do you recognize that really can be very impactful for a patient? It can be a good intervention in the home. Well, then, the hospital said, well, boy, if we send everybody home with incentive spirometer, that could be, have some budget restrictions. And so some of those kinds of things. So it was very interesting just to sit back and see how fragmented, although both sections were providing really good care, there really wasn't that coordination in talking about here's what's really a priority for us, and really this is a best practice. So we have a lot of opportunities to really continue those conversations, look at really what's most pertinent. I think for us, we want to have peace of mind, as you all do when you're caring for a patient, that no matter what, somebody comes back and says, what did you or didn't you do for the patient? You know what those priority focused areas are. With pneumonia, should we be using incentive spirometry? What should we be doing for this patient? Just so we know that we have good intervention there. I think in the last year you've heard us talk a lot about best practices. We want to make sure that we're using evidence-based practices to make sure that we're doing our part. We want to prevent those acute care readmissions. We want to make sure we're using that emergent care plan, always kind of going back to that and thinking of that really should drive what we're doing with the patient. And I think for all of us, we want to be the kind of provider where we're confident that we're not missing opportunities to better coordinate care. In home care, it's a big job. It's a lot of pieces. You guys know better than I do how much you have to do to pull everything in. And I think for us, we want all of our staff to be able to have that peace of mind of, I was able to do all the things I needed to do for this patient. And then I think just a couple other points, always focusing, and I talk about this with new orientees, our focus is to improve a patient's functional status. We want, and it's so important that we are able to show that patients improve under our care. A lot of our patients just stabilize, and we can't help that, but the majority of our patients really should improve under our care in a number of different areas. Hence, that's why, as you guys have patient focus meetings, you're seeing a lot about our outcomes. You've seen it posted throughout the office. It's important. We want to be able to show that. And then I think the other piece is that appropriate level of care at the right time, and we're not alone in this. When you think about individuals that we see in home care, that really, when you go out to see them for the first time, they look like a hospice candidate. They look like somebody who really should be served through the hospice team. But what we hear many times is, oh, well, the patient or the family is not ready. We hear that from acute care. We hear that from all over. And for us, we want to be the kind of provider that, okay, so what do we need to do? We can't just sit back and say, well, the patient or family is not ready. Okay, I'm looking at what's happening with this patient. Many of us feel like if you're not a hospice nurse, boy, I think that hospice team can provide a lot that is above and beyond what I do. So what do we do to make that happen? And so for us, it's really stopping what we're doing and figuring out, okay, is it Sherry Heavey? Is it Dr. Sauer? Is it a hospice nurse? But it really just speaks to, for any type of care, making sure that we get them the level of care and what they need at the right time. So many times we see patients that are in crisis, and we weren't able to intervene as quickly as we'd like, and all of a sudden we're in a mess. And that's not who we want to be. So, and I'm going to hand it over to Amanda to talk a little bit about clinical practice and.
Right. Good morning, everyone. Hey, before I start blabbing, I wanted to take this opportunity to introduce a few of our new faces that are here. And we'll start with a couple new clinical managers, but we have an old experience. First we've been here. Old face, Lori Parfit. And then Kim Acosta, which I think almost everyone was at the patient focus meetings. So this is Kim Acosta, and she's a new home care clinical manager. And for nurses, this will be a test on my names because I'm not very good. Currently in orientation is Danny, and she is on the wound team. And let me see, hold on here. And then we know, or do you guys make sure y'all know Christine and Amy on Med-Surg that were on orientation and have now moved over to the clinical teams, and Tanisha, who is in orientation as well and who will be on the wound team. And then our brand new faces. Lorraine. Lorraine is business development, but has a strong infusion background. And what that will help us with is at the med center, she'll be at the med center, and if there needs to be a hookup for infusion or things like that, she can also serve both as business development, but also serve as that nurse there. And then we have Beth. And Beth you guys just started, was it last week? Okay. So Beth, you'll be on the wound team, and like I said, she's brand new. And then we have Cindy in the back there, and cardiac, correct? Yep. And then Katie Berry, and I can remember your last name because I just want to say Katie Perry, which I'm sure you get that all the time, but I can't hold myself back on that. And Katie will be on Med-Surg, is that correct? Is that okay? So welcome everyone, and wanted to use that time. Clinical practice. We talk about our clinical practice. I know when everyone comes through orientation that Bridget sits down with you and talks about our clinical practice model, and it's on the internet, and I'm sure many of you refer to that many times at nighttime. But as a reminder, it's the care that we provide. So it is the assessment, it is your critical thinking, and making sure that the plan of care is carried out. The hands-on, what you do. I know we talk about clinical reg, and it's so critical that what we document reflects what we do. That's why we talk so much about our documentation, is because we know that we're providing this care, but it needs to make sure that it gets reflected in the documentation. But the hands-on interventions that you do as nurses, an evaluation of the patient's families and families' response to the interventions. So there's always that moment when you're in a home where you're doing the care that you provide, and then at some point there has to be that, whether it's on your drive to the next patient, of reflecting of what just happened, and what am I going to do for my next visit, as I summarize and think about, okay, they did respond to this, they didn't respond to this, I need to make sure I focus on this on my next visit. The focus on the primary nurse case manager model, and for those seasoned nurses that have been here a while, we've talked about this, and we've talked about this for a long time. And for those who were at the patient focus meeting, we had quite a bit of conversation about this. We are in a better place, I feel, for many reasons, than we've been before, I think, especially in this primary focus, and that is because of some changes that we've made with orientation. Really being able to prepare those nurses, matching them with preceptors, and preparing them to come to the clinical team better prepared and competent case managers right when they come over. The reason we continue to talk about this, and the reason that we made changes and recommitted ourselves to making this and ensuring that this is happening, is because the quality and safety of our care is dependent on the primary model. And What happens, though, is if we have some open positions, we struggle with this. But we need to then have case managers like Jill and Terry that can case manage, in their sleep and can do that and carry a larger caseload. And as we work to make sure that we bring in the right nurses like Katie and Beth and Amy, Christine, and bring in the right people to make sure we can continue on and serve our patients. The primary model, looking at the planning and provision of services that meet the needs, and on us too as managers and leaders to make sure that we have the availability of resources, whether that's the human resources, which is all of you, the financial, physical, the information. If you're on the specialized in wound care and now you have a patient who you deem might be appropriate for palliative care or hospice, do you feel like you have the information to be able to transition to that patient? And I can tell you that information is here in this room. We need to make sure that you reach out and that we reach back to you and make sure we get you that information. Ongoing evaluation, improvement of performance, and the use of evidence-based practices, which we'll get into. You are all nurses. And so when we talk about what you do, really, it is providing safe and quality nursing, period. So I guess if you walk out of here, it's to say that we all need to make sure we're providing safe and quality nursing on a consistent basis. We recognize this, that it does affect our quality and it does affect our financial outcomes. And we talk a lot about our financial outcomes, and we do talk a lot about our quality outcomes, which is exciting, and we've met so many great goals, and that all is back to what you went to school for. And why you came here. And why you came here is because you want to provide quality nursing care at the patient's level, in their home. Continue to focus on that excellence, especially in the day-to-day craziness of this. And when we are busy, and which we all are, and you all are busy all the time, to really sometimes to make those decisions, to really take a step back and saying, are we doing the right thing? Are we doing the best thing for the patient? Yesterday, there was, as an example, there was a patient that when we assigned all the admissions, he wasn't assigned, and so I got the email and that he was potentially going to be moved to tomorrow, and so today. And when I looked at it, he was a COPD exacerbation. I kind of all indicated that he wasn't really open to home care, but we needed to do the assessment. We need to figure it out and make it work. And so I think Sherry or Sylvia, one of you, stepped up and said, you know what, I'll be able to do this, and evaluated the patient. And that was the right thing to do. It would have been real easy just to say, I'll move him to tomorrow. But it was the right thing to do it, and we all worked together to make that happen. Your expertise, nursing expertise specific to patient-focused care, it's essential. It's essential to our success. Seeing that whole picture, and that's what, we talked about, that oasis. Yes, it is cumbersome. Yes, there's a lot of details. Yes, there's a lot of things when you get through the thing and you validate it, and you're like, oh, it's not validating. What little thing did I not click on? But outside of that, it can drive your plan of care. So that's, at some point, there has to be a 30-second pause of, what does this mean for the patient? What am I going to do for this patient? Meeting patients where they are. In the focus meeting, we kind of talked about that teaching style where you say, okay, I'm going to talk to you about what I'm going to teach you. And then you teach it, and then you say, okay, repeat it back to me. Explain to me what I just taught you so I didn't miss anything. Part of that is to recognize where they are. Where they are in their healthcare literacy, as we say, or where they are in the whole avenue of change. If you think about it, if I came in and I said, Angela, she's got long, beautiful brown locks, and if I came into her house today and I said, Angela, you're getting a haircut, and it's going to be as short as mine today, she might be looking at me like, okay, wait a minute, I'm not, whoa, I did not know that's what you're going to come talk to me about. I am not ready for that. I might be ready for it in a month, but I need some time to think about that. It'd be the same thing as if Jill went into a patient's house, and Jill knows what she's going to talk about. She's going to talk about this husband, but that his wife is not safe. They're not safe right now. And she's not only going to talk about how to keep them in the home, but now she's going to also start talking about their future, that they might need to look at other assisted living or bringing in somebody. And as she's talking about it, they're going to get some resistance. Now, it might be easy for Jill to walk out saying they're not compliant. I can tell you what, they didn't listen to a word I said. Or, as we know what Jill does, is that she feels out where they are and then comes and meets them at the level where they are. Okay, that's too much on that first day. Right now I'm just going to make sure that you're safe for this day, and I'm going to come back in a couple days, and then I'm going to bring in social work, and then I'm going to work to see and continue to evaluate how they move through that process of change. And that's where we are when we talk about meeting the patients where they are. That's what we just need to continue to think about. Accepting and managing noncompliance, because like I said, sometimes that noncompliance isn't that they're noncompliant, it's just that they're not ready for change. Fortunately, sometimes that might take years for them to move down that road, but some are quicker, and sometimes it's technique. It's all the approach that you have. Sometimes you find out, I always say we're kind of like amoebas when we go in their home. There's some that you can joke with and, pat on the shoulder, and then there's some that that you have to be pretty straight and narrow, but sometimes it takes a little while to feel them out. And appreciating and relying on other team members. Like I said, we have this room, we have, all the therapists and social workers and dietitians. So for all you current case managers, I know you know this, that have been here a while, all you newbies, don't feel like you're taking on the world when you're going into some of these situations, because we have a lot of resources. And basically being good advocates, and that when we're talking about safe, quality nursing care, that would equate to being advocates for your patients, because you're constantly thinking about what is best. In that primary nurse model, we talk about being responsible for the plan of care development, and we've talked about this before. You have wonderful clinical managers. Not one of them in a heartbeat wouldn't join you on a shared visit. They've seen your patients, they're continuing to case conference with you to know your patients and to continue to be that support. We talk about NTUCs, and those NTUCs, that's the acronym for not taking under care, another word for rejected referrals. Avoiding them because sometimes we don't identify the patient's needs. So yeah, we call a patient up on the phone, they said, yeah, I'm going to run a few errands. And they're like, oh, well, geez, okay, you're absolutely not homebound. Do you think you need home care? I mean, what do you think I can do for you? I'm like, I have no idea. I'm like, okay, you're probably not homebound, you reject the referral. Now, then we'll kind of talk about when we're identifying homebound status, how that might picture right there, because I don't know anybody who's going to admit that they're weak. Not many people do. Not many people say, gosh, I really do need you, Carla. I am miserable today. I mean, there are some, but very few. Very few are like, oh no, I'm good. I'm good. I had a surgery, but I'm probably on the golf course tomorrow. That's how they're going to put it off. So, utilize care path consistently, and that's part of our best practice, evidence-based. People didn't get in a room. We didn't put a room of experts together and come up with these care paths off a whim. It's off of evidence-based practice, research that has been done. And in that primary model, you can make most, if not all, of those patients' visits. We know in wound care, there's some, that might be a little bit different, but we know Terry, even though she can't see all those patients, we know that she is managing that care plan, and then she's seeing the patient at least weekly to guide through there. And then we know as we can move in this primary model, just how much more you've been there, how much more you're satisfied, the patient's satisfied, we have better outcomes. We talk about 24-hour accountability. That doesn't mean that you're on call 24 hours a day, but what it means is that when Jill's off tomorrow, she knows who needs to be seen. She knows. She knows that if there's a patient that's kind of one of those that could have an acute need that day that she's off, she knows she's going to talk to Sherry and say, Sherry, this person might come in or call in, and we might need to get them seen. Or she might talk to Daler or a peer and say, hey, I might need you to see this patient tomorrow. She knows that and communicates that and pre-plans. Communicating with other disciplines involved and then integrating the plan. So it's not the nurse just goes here, the PT does this, and the OT does this, and the health aide comes in 3 times a week. It's coordinating that whole plan, communicating. Hey, where are you on this? Okay, well, let's see, let's see, when do they have their labs? Okay, well, we could work, if PT could work on car transfers and stairs, they could probably start going in for the labs, and I can discharge because my teaching is pretty much done now on that, and I know what I can focus on and communicate with the physician, and that's that primary model. And again, best practices. What is best practice? What is considered the most appropriate, a technique or methodology that through experience and research has reliably led to desired outcomes. So it's not just a whim. It seems to work, I'll go with that. We have a room full of fantastic nurses, how Christine approaches a nurse, and how Rosemary and Amy, it might be very different in some of the mannerisms that you have and your personalities and things like that, and that's what makes us wonderful. That's what makes us us. But if you're talking about reaching a desired outcome to heal a wound or to prevent rehospitalization because of CHF, there are certain things that we need to do consistently, and that's why we have those care paths that need to be utilized. So even though there's a variety of people in the room, whether it's Joe Smith or John Smith, they're getting the same care, the same things are being taught. And so we must improve those assessment tools and practices so it's consistent. And that's what we talked about even on the OASIS, those best practices, those process measures where they talk about the depression scale and the pain assessment and all those. Again, that wasn't just something that CMS said, oh, this is one more page we can add to the OASIS. It's for a reason. And there's a reason why we make sure that we are doing those and implementing them on our plan of care, because it's the right thing to do and it's the right thing to achieve the best outcomes for our patients. We have a standardized admission process, communication with the physician, and some of these we're going to talk in a different in-service about SBAR. Man, I bet you that takes you back to some school there about what even SBAR stands for. Don't ask me though. Teach-back process, helping patients identify goals and their end-of-life options, involvement of the other disciplines, evidence-based practice, care paths, and use of technology and telehealth. I can tell you the home and monitor isn't just this nurse in a machine, as one of our patients called. It's there for a reason, and it's to prevent rehospitalization. So why not use that to our advantage? So if someone, we call into Michelle and we check our trends and the patient's stable and you've made one visit this week and you seem to be good, you might not need to make a second visit that week. You might be able to say, hey, you know what? You call into the patient, things are going well, and maybe then you see him the following week. Two things that I'm going to go over. I'm going to talk really fast. Admission process and the review of skilled service. Okay? Bridget is handing out. Everyone has seen these before? I'm hoping everyone will say, yes, I've seen them. It would be one of our VNA's best practices, because in admission, you can walk into admission and it's just overwhelming. There's a lot to accomplish. You see this patient and it's like, I don't even know where to start and where I need to go with this. But this will help you streamline the process, and it also prepares the patient for what's going on. Our clinical liaisons give these to patients. When they have an opportunity to see a patient in a facility, they give them one of these. So that way the patient knows when Michelle Wakefield calls me and says, I'm coming out for an admission today, they're not going to be thinking, oh, well, that's fine, because it'll take about an hour. That's all right. Young and the Restless is on soon. They will be prepared, okay? And then Michelle can actually talk through some of these. Now remember, I'll be out there for about 3 hours, okay? And I need to make sure we have your insurance cards and your medications, and that we should do right on the phone, right when we're calling to schedule the admission. And so step 1, okay? And it also prepares you and helps kind of format that process and how that would work. The first thing you do when you walk into a person's home, and they come, they answer the door, immediately your eyes are going. You start even thinking about the patient when you pull up, because you're looking at, okay, where do they park their car? How are they going to get? It's a split-level home. How do they even get down? You're already thinking, how do they even get to the doctor's house here? And so you go in and you say, I need to come in for a second, and I want to check you out and evaluate you for services, but I need you to sign this consent form to make sure that it's okay. So that's the first thing. And as they're signing, you're also evaluating. They might have sat down to do that. How did they transfer? Are they stable? Is there balance? What's their vision like? Maybe they can't read. You can assess, and all we have right now is we just have a signal. You've been in the home 2 minutes right now, and you've gotten all of this information already. You review their insurance cards. We have this nice packet. You do not need to go page by page by page with it. A lot of it is, okay, I need you to, tonight or later on today, just go through that. There's a home safety checklist we want to make sure. And so that kind of highlights. And then guarantee that if this is on there and the patient sees this, they're going to make sure that you go over it, right? And so it puts you in a spot and them in a spot, in the same spot, which is nice. Then emergency care plan, when we talk about what level you are as a patient. And then you say, let's walk around your house. Just show me where your meds are, show me where your bathroom is, and that's what we call in orientation. They call it the Oasis Walk. And you learn about everything right there. Where their meds are, how they can reach up, if they can't reach up, get in and off the toilet. And that's in the first about 45 minutes of the time that you're there. So as you're looking through the medication, you're matching it up with what the hospital has sent home or the discharging facility, making sure that there's, gathering the patient's knowledge. I don't know what these are for, and you're saying, let me see all your over-the-counters and all of this, and they pull out meds from 1999, and do you use these? I don't really know. Sometimes I do, and and you're like, okay, all right, now I know. Right now I can tell you what one of the big things I'm going to do, and that's medication management. Because not only are you needing to teach them for that visit, but at some point you're going to discharge, and you don't want to come back, in 2 years from now, and then they have meds from 2011 sitting there. So, it's the kind of I think the term they use is perseverance of medication management. So teach them now, so for the rest of their life, hopefully the only time you'll see them is at a restaurant.
I think the other thing, Amanda, is when they get their HCAP survey, and it said, did anybody from the agency talk to you about your medications?
Mm-hmm.
And
Yep.
you've shown them that, it reinforces in their mind that you did it.
Yep, absolutely. And then the step 3, in the right above, which is not on the slide, but on that step 3, we've added confirmed schedule follow-up physician appointment. Let's save Medicare about $1 billion and get these people back into their physician for a follow-up within 7 days of discharge. Hospitals are really working very hard to get those scheduled prior to discharge, but we need to ask, do you have an appointment scheduled? When is that? And how are you going to get there? And if you don't know right then and there, or they don't know, or they don't have one, you call the doctor and said, she's been in the hospital, she's home, we need to get her in within the next week. And then you call your social worker and make sure they come out and we get this arranged. Or your PT to make sure they can get them down the steps. And then in that third step, then you're doing your treatments and your teachings as needed. When we talk about skilled nursing care, Bridget's going to hand out these cards. These cards we have made for our clinical liaisons and our business development to hand to our referral sources. On here there is skilled definitions of what is skilled nursing PT and speech, the Medicare definition of homebound, coverable services. They talk about the face-to-face document. It's essentially a cheat sheet. So for those referral sources that are like, oh, you need blood pressures, okay, the VNA probably can come out every day and check your blood pressure and there's nothing else going on. Yeah, this will help them so those types of referrals don't come through. But it gives a better understanding, too, of what the VNA can provide, what is home care, and everyone's on the same page. For the skilled nursing, you have the observation assessment, skilled procedures, which are your PTAs that you put on your service codes. I just want to mention about observation and assessment. Let's say a referral that we just said yesterday, the patient was hospitalized for just some mental status changes, didn't really define anything, was there for a couple days, and discharged. And then a conversation that I was part of was, I don't even think she needs home care. She was pretty independent before that. What does she need? Medicare, they will say, you know what, go out and observe and assess and make sure that patient is stable. And they can give us a 2-week window to say, hey, you know what, make sure that they not only know their medications, know when to take them, know other signs and symptoms, and make sure that they are stable. Because 2 days of mental status changes for a person who has never had them before and then they send them home, I don't know about you, but if that happened to me, I'd be like, I want some eyes on me because that's not right. Something is going on. And so that's our job to go out and observe that, and we can observe and assess. Homebound criteria. Medicare has, I call it, lightened up their regs. So for those who've been here, longer than 8-10 years, we used to kind of think the moment they step out the door, boom, they're gone. What Medicare really is smartened up here and said, you know what, let's just kind of think about this a little bit, because home care, let's welcome to the world of gray. We're not black, we're not white, it is just strictly gray, and that's the world we live in. And so let's look at it on an individual basis, because there are a lot of what ifs, ands, and buts that can come in between. So essentially, they're confined to the home, and so if they are confined to the home, typically they need some sort of assistance, okay? It still says it must be a considerable and taxing effort for someone to leave the home. They might need some supportive devices to assist them with that. Acceptable reasons for leaving their home. You have your, they drive around the block. The family says, you know what, I'm going to get him outside. Good God, it's supposed to be 71 degrees and sunny all week next week. Get him out of the house. Let him enjoy a little vitamin D here, That's okay, because what you're looking at is the functional ability. Was it a taxing effort for them to leave? Yes, it was. So you call up your patient, Rosemary. You're getting ready, thinking about, you're in the middle of your plan of care, not ready to discharge. You call them and they say, you know what, I'm going to go to the grocery store today. Oh, how are you going to get there? I'm going to drive. I think I can do it. And Rosemary's like, good one. All right. I don't think that's wise, but if that's what you think you're going to do. And Rosemary says, you know what, I'm going to call you tomorrow morning and I'm going to see how it went. So she calls them, and then and they say, calls at 8, no answer, calls at 10. I just get out of bed. I'm so tired. My legs hurt. When I got to Walmart halfway through, I had to get my cart, and it was terrible. Okay, you know what? You're still homebound. Yep, I'm gonna come out later today, and we're gonna continue on our plan of care. Because people are going to try, they think they can do stuff. Oh, I shower by myself all the time. Well, up until now, you've been home 12 hours. You don't even know if you can get in the shower, So we have to be kind of thinking just a little bit of a little skeptical eye there. So if someone wants to, they have a family wedding, enjoy and have a good time, because we know it's their functional ability that we're assessing. Now, if they had, I can be homebound for a weekend when it's cold and snowy and I don't want to go anywhere, but that I wouldn't qualify because I physically could, I just choose not to. Okay, so again, it's not a choice. We will never, ever see in anyone's documentation not admitted because they refuse to be homebound or discharged because they refuse to be homebound. It is not a choice. It is their ability or their lack of ability to do that. So what you might say is they were not admitted because they didn't meet regulations because they are independent ambulators. They are not short of breath with any exertion. They have no balance difficulties, and you can then paint your picture, but it's not because they just refuse. CMS actually states it's determined on an individual basis, looking at the patient as a whole. Okay, if the net effect of driving indicates that the individual has a capacity to get their health care routinely outside of the home, then that might challenge their eligibility. However, if a patient's fit enough to drive raises questions of whether the requirements are met, then they could still meet home care criteria. Is that new for anybody? Does that make sense? And I know, and please, you're going to go, and then, like I said, we live in a world of gray, so you're going to be out and you're going to be like, gosh, I don't really know. It's hard for me to say. And that's what the discussion you can have with your clinical manager about. I've said, and do not document. The condition is either that they are or they're not. Either they have a difficult time leaving or they don't, but it's never a choice. And so this could be your supportive documentation. Okay, so if you don't admit because they truly are not homebound, you post why. They have no shortness of breath, they're independent ambulators, they have access to the medical appointments, they can leave the home without difficulty, that whole message there. And this is the last slide, and this is where we are, and just a little over. Again, we talk about what, I think in the world of craziness, you need to take 30 seconds and you say, why am I here? I'm here because I'm a nurse. I want to be in the home. I want to meet the patients at their level, and I want to make a difference. And by doing that, that's your patient-centered care. We make sure that they are, know their medications as much as they can. And if it's not them, then it's their caregiver. And if it's not them, then you talk with the physician or the pharmacist and what we can do. Making sure that they see their physician early and ongoing. It's important. Symptom management, what that means, what they're supposed to do. And self-management, ongoing. You will be discharging at some time. You don't ever want to tell a patient, I'll be discharging tomorrow until your home health aid ends tomorrow. Be thinking, what is going to be going on once I'm not in your world anymore? And those are, put yourself in that position for those patients. It's a lot of information. Anybody have any questions or comments? Okay, thank you so much for your time. Enjoy this last day of summer. It's supposed to be cool next week.